Hello and welcome to this Dry Eye webinar on the 15th of June 2020. The time is 9 p.m. here in the UAE. I would like to welcome all of you attending from whatever part of the world you're in. Welcome to this webinar. We'd like to thank Lunatis, as always, for the support in all these educational programs. My name is Gerard Moore from Focus Gulf Conferences. I am the webinar support manager. If you have any technical issues or you have any issues surrounding the webinar, you can send me a private message or an admin message. These are on the right hand side underneath your chat bar. As many people are already typing, you can see the chat bar is open for discussion, comments or questions to Dr. Mazen Sinjab today. So please feel free to type any messages. You can send private messages to me if you wish to remain anonymous, and we will review them later. If you have any technical issues, your video or audio is delayed for whatever reason, you can simply hit the reconnect button at the top of your screen. This webinar is recorded and will be live for 3 days after the event. We have one speaker, Dr. Mazen Sinjab, and he will speak for 1 hour today. This is an accredited program, and you will receive your certificates 1 to 2 weeks after the program. I would like to hand you to Mina Ashraf from Lunatis to give the formal opening. Mina, the floor is yours.
Okay. Thank you very much, Gerard. Ladies and gentlemen, good evening. It's a pleasure to have you on this CME accredited scientific webinar. So on behalf of Bosch Health and Lunatus, I wish you a very nice event and a very nice evening. And I'm sure we will all learn a lot from Dr. Mazen's experience in the management of dry eye. Today we have a very eminent speaker, Dr. Mazen Sinjab. Dr. Mazen is a consultant ophthalmic surgeon in Medcare Eye Center, Dubai in the UAE. Dr. Mazen is specialized in laser vision correction and other refractive surgeries, as well as cataract surgery and surgical management of keratoconus. Dr. Mazen has a PhD in ophthalmology from the Faculty of Medicine in Damascus University. Dr. Mazen also is the scientific ambassador of the Light for Sight Foundation in Switzerland. He's a fellow of the Royal College of Ophthalmologists in London, UK, and he has a certificate of laser and refractive surgery from the Royal College of Ophthalmologists in London, UK. So on behalf of Bosch Health and Donatus, and on behalf of all the attendees, I'm welcoming Dr. Mazen. And I just want to say thank you very much for being our speaker for tonight. And the floor is yours. Thank you very much. Dr. Mazen, I think your microphone is muted, so.
Dr. Mazen, I think your microphone is muted. The microphone button, the blue button at the top. We can't hear you, Dr. Mazen. We still can't hear you. No. Can you take your mic? Can you take your lead out, please, and take your wires out, please? No, can you take your wires, your microphone out from the? No, we still can't hear you. Is your mic? Is the blue button on the top? Is it on blue? Can you maybe try to log out and log back in again? Let me just try. Just excuse us, ladies and gentlemen, for one moment. It seems there was some audio issues with Dr. Mazin, although he was in the room with us for a long time. It was working fine. We will just wait till he logs back in, and I believe maybe he will be working fine when he comes to join us again. So thank you once again for joining us, and please, if you have any questions and comments, please feel free to use the chat bar. You can write in English and in Arabic. Mina and I will monitor both of them. So see if Dr. Mazin joins us. Hopefully the audio will be with us.
Hello.
Hello, we can hear you, Dr. Mazin.
Okay, great. So you can hear me now.
You can go ahead and share your screen.
Okay, thank you very much. Thank you very much. I'd like to thank Lunatus for this kind invitation. It's my honor and pleasure. And let me, yes. So I would like to thank Lunatus for their kind invitation, and special thanks to Mr. Mina Ashraf for the invitation, and it's my honor and pleasure to be in front of you today. And special thanks to the UAE Lunatus group, and I'd like to thank Gerard for hosting this meeting. So can you hear me very well? Can I go on?
Yes, we can hear you clearly. Thank you.
Yeah, great. Of course, I don't have any financial interest in any of the products or tests that will be mentioned in this presentation. Actually, there are some myths that are very common in the diagnosis and treatment of dry eye, let's say amongst people and amongst ophthalmologists and pharmacists. So let's say that the first one is it occurs just when it stops raining. And this leads to the misconception number one, that watery eyes are not dry. Myth number two, it just causes dryness, redness, and irritation. Now, this leads to the misconception number 2 and 3. The dry eye is diagnosed by symptoms. For example, if the patient is suffering from dryness, then there is dry eye. And this will be, of course, leading to missing to other symptoms that are caused by the dry eye. Misconception number 3, that there are no other effects of the dry eye. For example, blurring of vision, affection of performance, and a lot of things that we are going to see later. Myth number 3, the magic recipe. I mean by the magic recipe, these disastrous medications that are used and they are prescribed over the shelves in the pharmacies without even a prescription of the doctor. And these medications will affect the vasomotor complex, which has a very deep impact on the dry eye and ocular surface. And actually, these drops are addiction drops. I mean, the addiction, dependence of the patient. He will depend on these drops, and this will lead to a vicious circle, which means that the eyes will be red, and the patient will use these drops in order to get rid of the redness, but this will cause redness again. So the patient will come with a disaster. So actually, this will lead to the exaggerating of the disease. Myth number 4, there is only one and only one solution, which are the lubricants. Of course, this is a myth because there is a lot of other options of treatments that should be used in addition to the lubricants. So misconception number 5, this leads to overuse of the lubricants, and this will lead to misuse of the lubricants. Now, what's the difference of overuse of lubricants and misuse of lubricants? Overuse means that even if the patient doesn't have any symptoms, they will use the lubrication in order to avoid a dry eye. And sometimes the symptoms are not related to the dry eye, for example, are related to the allergic conjunctivitis or other diseases, and they use the patients use the lubricants. There is a misuse of the lubricants because not every lubricant is suitable in a stage of dry eye, because as we will see later, the dry eye treatment is a staged treatment. So there are special lubricants that can be used in all stages, and there are special lubricants that should be used in specific stages. Misconception number 7 is ignoring other treatments, because if we think that the lubricants are the only solution, then we will ignore all sources of and all causes of dry eye, and we will not use any other medications which are very essential in the treatment. Myth number 5 is no flame under the ash. This will lead to the misconception number 9, missing the inflammatory cascade, which is something fundamental in the vicious circle of dry eye, as we will see later. I mean by this that inflammatory cascade is existent in every case of dry eye, regardless of the grade of the dry eye, whether it is mild, moderate, or severe. Always there is an inflammatory cascade. Now, the last myth is dry eye disease is unbeatable. So this will lead to the misconception number 10, missing the proper weapons for the battle. I mean by this that if we know the sources of the dry eye, the causes and the background, if we treat them very well by using the proper weapons, then we can beat the dry eye as much as possible. So, of course, we can beat the myths by facts. Now, the first fact about dry eye, that it affects quality of life. We will see later how it affects quality of life, but for sure, it affects quality of life. It does not only affect the eyes by causing the dry eye or irritation. The very important point in corneal cataract and refractive surgery that dry eye affect the accuracy of measurements before the operation, and they will have a very bad, the dry eye has a very bad impact on the outcomes and results. So diagnosis of dry eye, classification of dry eye before such treatments or for such surgeries is fundamental, and it should be treated properly before doing such surgeries to avoid any complication. We have to know that there is no single test that can say that this patient has dry eye and can classify the dry eye. What I mean is we have to depend on a collection of symptoms and signs and tests in order to say that this patient has a dry eye, because of many entities that may mimic dry eye disease, as we will see later. We have to put in mind that dry eye disease needs a chronic therapy and needs patient compliance. So patient education is fundamental in the treatment of dry eye disease. And we have to tell the patient that there is no magic touch. There is no single treatment. We have to go into staged, and we have to discuss his environmental, his lifestyle, everything about the patient. And we have to spend sufficient time in the first visit, that when the patient comes, we have to spend sufficient time about discussing all the surroundings of the patient and education of the patient about how we are going to treat the dry eye in order to get very good patient compliance. Otherwise, patient non-compliant will be our fault. It is not the patient's fault, not the patient mistake. Omega-3, actually, this is controversial. Although there are many studies showing that omega-3 has no effect on the treatment, it is like a placebo, but from my personal experience and from my colleagues' experience and from many ophthalmologists' experience, omega-3 improves the secretion of lipid layer and improves the quality of the tear film, and it has a very good role, although it is not scientifically approved. Topical cyclosporine has a very important role in suppressing the inflammatory cascade. And recently, the topical liftigrast, like Xidra, eye drops, has a very big role and on suppressing or breaking the chain of the T cell reaction during the inflammatory cascade. So we have to put these two drops into account. Sjogren syndrome is very important to be diagnosed because primary Sjogren syndrome is one of the sources of malignancies. So maybe the first manifestation of Sjogren syndrome is dry eye disease. And maybe as a doctor and as a pharmacist, maybe we are the first one to see this patient. And if we put this disease into in our minds when we discuss with the patient, and even we sometimes refer the patient if we have a doubt about this disease or other immune diseases, we have to refer the patient to a rheumatologist or physicians specialized in immune diseases in order to detect such diseases. So if we detect such diseases, sometimes we prevent malignancy from developing in the future for in this patient. So I'm going to go through these steps or these points in my presentation, and I will start with the pathophysiology. What is the pathophysiology of dry eye disease? Well, we have to remember that there are some components important in ocular surface system. They are, of course, the lacrimal gland affected by the nervous system and affected by hormones. There is the nerves in the cornea. There is the vascular complex in the conjunctiva. There is the goblet cells in the conjunctiva, and we have the tear film itself. So we can say that the ocular surface components are the lacrimal glands, the epithelium of the cornea, limbus and conjunctiva, goblet cells in the conjunctiva, meibomian glands in the lids, and the mucoepidermal junction of the lid. So all of these compose the tear fluid, blood, systemic hormones, nerves, cytokines, T cells, elements in the vicious circle of the dry eye disease. As we all know that there is like a feedback cycle between the ocular surface and the lacrimal gland and the central nervous system. So whenever the ocular surface is healthy, then there will be a balance in the amount and the quality of the tears secreted by the lacrimal glands, and this will give a feedback, positive feedback to the brain. So the indicators of the ocular surface health are the tear film stability, ocular surface mucin, the vessel condition, conjunctival goblet cell density, epithelial permeability, touch or pain sensitivity, blink rate, and quality. So whenever we have dry eye disease, there will be tear film instability, there will be a disruption of the ocular surface mucin, there will be disturbance in the vessel condition, there will be lack of goblet cell density, as we will see later. The epithelial permeability will be affected, and even the epithelial migration and replication will be affected. Touch or pain sensitivity, this is why we need to check corneal sensitivity in every patient of dry eye disease, because lack of sensitivity is a fundamental component in the dry eye disease, chronic dry eye disease that does not respond to the treatment. Blink rate is affected. Sometimes we find low blink rate. Sometimes we find frequent blinking in dry eye disease. And so we can say that the main pathology of the ocular surface disease are mainly three components: the nerves of the cornea, goblet cells, and the vicious circle. Now, the vicious circle is Dry eye will cause a hyperosmolarity of the tear. The hyperosmolarity of the tear will cause like cytokine release. The cytokine release will initiate the inflammatory cascade. The inflammatory cascade, whenever initiated, then there will be tear dysfunction and instability, which by itself will cause nerve stimulation, and this will cause hyperosmolarity of the tear and again and again. So this will cause ocular surface disease, specifically dry eye disease. In addition, there is a main factor that we have to put in mind, and it's growing day by day. The evidence is growing day by day about it, which is the T cell role in the inflammatory cascade, because in dry eye disease, there is an overexpression of what's called ICAM1, which is an intercellular adhesion molecule. And this is related to lymphocyte function, and this is why a new drop is in the market nowadays, which is the liftigrast, Xidra, in order to stop this chain at this point. So the T cells, as we said, have the role as follows. There will be, in the dry eye disease and ocular surface disease, there will be changes in the ocular surface. These changes will initiate some toxins. Those toxins will initiate stimulators to the lymph nodes. The lymph nodes correlated to the ocular surface will start secreting T cells. The T cells will migrate to the ocular surface, and they will initiate more and more inflammatory cascade. Now we come to the T-FOS-DUCE2 report for the definition of the dry eye, because it's very important to define the disease before we treat it. Otherwise, there will be misconceptions, and we will not talk the same language. So the T-FOS-DUCE2 report is a huge work done by authors after 10 years of work after the T-FOS-DUCE1. The T-FOS-DUCE2 report came in 2017 with this definition of the dry eye. The dry eye definition, according to T-FOS-DUCE2, is a multifactorial disease. So as we see, the dry eye is a multifactorial disease. So treatment of the dry eye is, at the same time, is multifactorial. It causes loss of homeostasis of the tear film, which leads to tear film instability and hyperosmolarity. So in every case of dry eye, there is hyperosmolarity. So hyperosmolarity is a test that should be done in order to confirm the dry eye disease, one of the tests. And ocular surface inflammation and damage. So as you see, in every dry eye disease, there is inflammation and there is damage, in addition to neurosensory abnormalities. So we have to put all these terms in mind when we treat the dry eye disease. There are consistent risk factors of dry eye disease, including age, sex. When I say sex, sex is not gender. What's the difference between sex and gender? Sex is the genetic expression of a person, while the gender is the way this person would like to represent himself. So we are talking about genetic expression. There is as well meibomian gland dysfunction, connective tissue diseases, Sjogren syndrome, androgen deficiency, computer use, especially nowadays with the COVID-19, we are spending long hours on the computer, contact lens wear, estrogen replacement therapy, hematopoietic stem cell transplantation, certain environmental conditions, and some medications, such as antihistamines. Probable risk factors include diabetes mellitus, rosacea, viral infection, thyroid disease, psychiatric conditions, pterygium, low fatty acid intake. This is why omega-3 has a role, as you see here. Refractive surgery because, especially LASIK, because we cut the nerves by creating the flap, and there will be lack of sensation in the cornea. In general, any ocular surgery will affect the nervous complex in the ocular surface, allergic conjunctivitis, and some medications. Inconclusive risk factors include Hispanic ethnicity, menopause, acne, sarcoidosis, smoking, alcohol, pregnancy, Demodex infestation, botulinum toxin injection, multivitamins, and oral contraceptives. What about the epidemiology? Actually, the dry eye disease is a very, very, very common disease. In my daily practice, almost 70% of my patients, they have dry eye disease. And of course, it is more prevalent in women than in female, let's say in female than in male. And according to many studies, it increases by age. What's the impact of the dry eye disease? The impact, let's say there is a general impact and there is an ocular impact. Regarding the general impact, it affects quality of vision, it affects quality of life, it affects work productivity, and it affects the psychology of the patient, and it may lead to depression. And there are few cases reported about suicide because of the severe dry eye and the caused pain. So all of this will cause economical burden. Now, what about the impact on the eye? There will be tear film instability, which by itself will cause corneal irregularity, which by itself will cause changes in the epithelial hypertrophy. This will induce high-order aberrations. The patient starts suffering from glare, shadows, fluctuation of vision, ghost images. So the quality of vision will be low in spite of good visual acuity. There will be wrong care reading measurements. These care reading measurements, if they are wrong, then we will have wrong results in refractive surgery, wrong results in cataract surgery. The blurring of vision because of unstable tear film. Actually, there is a correlation between the instability of vision and the instability of the tear film and the osmolarity itself as well. When the osmolarity exceeds the 326, then there will be instability of vision. About the classification of the dry eye disease, according to Diagnoses 2, we know that the tear film consists of mucin layer on the cornea, the aqueous layer in the middle, and the lipid layer, which is the outer layer and protects the tear film from evaporation. Now, according to Diagnoses 2, we can classify the dry eye into evaporative and into aqueous deficiency. Although this is scientifically true, but there is a mixed type, and most of the dry eye diseases, presenting into the clinics are of the mixed type, which means that there is an evaporative in every case of dry eye disease, while aqueous deficiency may be there, maybe not. Let's say that the evaporative component is 3.5 folds more than the aqueous deficiency, and the mixed type is the most common one. So back to this chart. Actually, I'm not going to bother you with this chart, but it is the same vicious circle which we saw a few slides back, that the case starts at any point of the circle. Like, for example, there is a problem in the meibomian gland, there is a problem in the corneal sensation, there is a problem in the lacrimal gland, in the lid margin, any problem, then this vicious circle will start. But the keystone of the problem is the tear hyperosmolarity, which will lead to breaking of the lipid layer and destroying the goblet cell in the conjunctiva and evaporation of the tear. Now, regarding the meibomian gland dysfunction or the MGD, there are main two types, let's say the cicatrical one and the non-cicatrical one. And this might be related to the age, because by age we lose some of our meibomian glands, and sometimes because of cicatrical conjunctival diseases. Now, what is the differential diagnosis of the dry eye disease? According to Tifos Deuce 2, there must be symptoms and signs in order to say that there is dry eye disease. If the patient has symptoms but has no signs, then we have to think about things that not related to the dry eye disease, such as neuropathic pain, and in some cases, they may convert into dry eye disease. So we have to monitor them, but we have to know why they have symptoms without signs. So maybe we will need like a neurological consultation. And some patients may have signs, but they don't have symptoms. So if we find some signs of ocular surface disease, but no symptoms, then we have to think about neurological conditions as well. But some of them will convert into dry eye disease, so we have to monitor them. So in general, there must be symptoms and signs in order to say that it is a dry eye disease. Now, whenever we have symptoms and signs, there is an ocular surface disease. It is not only dry eye disease. Okay, so let's say symptoms and signs, then there is ocular surface disease, which one of its components or one of family member is the dry eye disease. There are a lot of other members like the anterior blepharitis, allergic conjunctivitis, corneal EBMD, contact lens intolerance, conjunctival chalasis, a lot of things like computer vision syndrome, pterygium, recurrent corneal erosion, a lot of other components or other members in the family of the ocular surface disease other than the dry eye disease. So how to differentiate these two entities from each another? We have to look at the osmolarity. If there is hyperosmolarity, then it is dry eye disease. So as you see, till now we have symptoms, there must be signs, and there must be hyperosmolarity in order to say it is dry eye disease, because there are other entities under the umbrella of the ocular surface disease causing the same symptoms and signs, but they are not associated with hyperosmolarity. We come to the diagnoses. So we can very clearly establish the diagnosis as recommended by the Tifos Deuce 2, that there must be symptoms. In addition, one of the following markers, which is non-invasive tear film breakup time, hyperosmolarity, ocular surface staining. So if we have symptoms and one of these positive, then it is dry eye disease. Otherwise, it is an ocular surface disease other than the dry eye disease. What about the symptomatology? We have to use like a questionnaire. We have to give the patient a questionnaire. It is not sufficient to ask the patient about the symptoms and signs, because there are specific questions, and even these questions, they have specific grading. So according to the score, the final score, we can say that the symptomatology of the dry eye disease is positive or negative. Unfortunately, as physicians very busy in our clinics, usually we don't use this. Personally, I use it, but I mean, in general, we don't use it because it takes time. And but if we want to be academic, we have to give it to our nurses, and they can spend some time with the patient, asking the questionnaire and explaining about this in order to establish the dry eye disease diagnosis. So according to that, if it is positive, then we look for other markers, which one of them is the tear film breakup time. The tear film breakup time can be done either by installation of fluorescein drop into the eye, or by using special devices to without installing any staining drops. Whenever it is less than 10 seconds, then it is positive sign. The hyperosmolarity. Now, before I tell you about the test of hyperosmolarity or osmolarity, we have to know the effect of the osmolarity. In general, there are microvilli in the surface of the epithelium, and these microvilli are very important so that the glycocalyx materials will be adherent to the microvilli in order to make the first layer of the tear film that maintain the tear film. Now, When the hyperosmolarity starts, then there will be toxic tear film. The toxic tear film will cause cell stress. The cell stress will cause cell death, and the microvilli will disappear. And as you see by this immunomarkers, that on the left, the normal appearance, in the middle, mild to moderate cell death, and in the left, on the right, the severe cell death. After that, there will be apoptosis, and finally, the inflammation will start. Now, in a study, there was a comparison about the different types of tests that we usually use in clinic in order to diagnose, for example, a dry eye disease, like Schirmer test, the tear film breakup time, meibomian scoring. I have to. Yeah, meibomian scoring, the OSDI, corneal staining, conjunctival staining as osmolarity and osmolarity. Now, the osmolarity is the most valid, let's say valid and repeatable test that we can depend on. How it is done? By using special devices. I have no financial interest, of course. We have to check the tear film osmolarity. It will give us numbers. Now, we say that it is there is hyperosmolarity when there is 308 milliosmol per liter in one eye, or there is a difference of, or more, or there is a difference of 8 or more milliosmol per liter between both eyes. In this case, we can say there is hyperosmolarity. The last one is the ocular surface staining. The ocular surface staining, of course, we have to use special dyes, special stains to stain the cornea, to stain the conjunctiva, to stain as well the lid margin. We can say that ocular surface staining is positive when there are more than 5 corneal spots, or more than 9 conjunctival spots, or on the lid margin, there is more than 2 millimeter length and more than 25% width of staining in the lid margin. These are examples of lid margin staining. More than 2 millimeter length and more than 25% of width. There is like another test that we can do in order to evaluate the severity of inflammation. Inflammation is there in every dry eye disease, but if we want this to check the severity of the inflammation, then we have to go for the MMP9 test. We take a sample of the tear, and then we wait, we look at the indicator, and according to the darkness of the indicator of the pink line, whether it appears or not, then we can say that it is positive or negative, and whether it is severe or not severe. However, if it is negative, it does not exclude the inflammation, but we can say that the inflammation is low enough that this test could not detect. This is very important. Finally, we come to treatment options. Treatment options, the first keystone in treatment options is patient education. Patient education is half the treatment. We have to spend sufficient time with the patient educating in order to get his compliance. Otherwise, any treatment that we will use will not be sufficient and there will be a failure. Second, we have to discuss with the patient the local environmental circumstances, like AC, water, drinking water, for example, spending long hours on the computer or digital, like the mobile. So a lot of other things that should be discussed with the patient. Then we can move to treatment for tear insufficiency, treatment for lid abnormalities, anti-inflammatory therapy, dietary modifications, complementary medications, and in some severe cases, specific cases, we may need surgery. So in a stepwise approach, we can say that, first of all, we have to reduce aggravators, like we have to provide gentle environment to the patient. We have to treat blepharitis and look for Demodex sometimes. We have to review oral medications if the patient is on oral medications for other reasons. We have to control systemic diseases. Then we use the lubrication. The lubrication, of course, we have to look for the proper lubricant, and sometimes we may use the punctal plugs. I say sometimes we may use the punctal plugs because punctal plugs should be avoided whenever there is a clear inflammatory cascade on the ocular surface. When the ocular surface is diseased, we have to treat the inflammation first. Otherwise, if we put the plugs, then we are going to make the toxins more and more. They stay on the surface of the ocular surface more and more time, and this will cause exaggeration of the problem. So we put the punctal plugs after we treat the ocular surface. Anti-inflammatory like the cyclosporine, the liftigrast, the azithromycin as well, oral tetracycline in some cases. The last result is the autologous serum and the surgical approach. And finally, if all of this failed, so we have to consider corneal neuropathy, and we have to refer the patient to a neurologist, for example. And don't forget that during this step-ladder approach, we have to always think about a background, the immunological background of the patient, maybe Sjogren's disease or other diseases. Now, to finalize the presentation by the types of the tear, let's say, substitutes in the market, we have to go through very quickly about the composition of the normal tear film. We all know that the tear film is composed of a mucin layer, which is adherent to the corneal surface and conjunctival surface, of course. There is the aqueous layer in the middle, and there is the lipid layer in the front. The lipid layer, or the lipid component, is secreted by meibomian glands of the lid, mainly. The aqueous component is secreted mainly by the lacrimal glands, main and accessory. And the mucous component is secreted by corneal epithelium and goblet cells in the conjunctiva. Now, for the mucous component, which is secreted by the corneal epithelium and goblet cell, it smoothens the cornea and the conjunctiva. It improves the wetting of the cornea, and it is very essential for stabilizing the tear film. We come to the aqueous component, which is secreted by the lacrimal glands and main and accessories. It's very important for transportation of enzymes and proteins, flushing out foreign bodies, oxygen transport, and it has an antimicrobial property. The lipid component, secreted mainly by the meibomian glands of the eyelid, it has a hydrophobic barrier which prevents evaporation. It enhances surface tension of the tear film, so the breakdown of the lipid component will cause hyperosmolarity. It moistens the lid margins, which is very important for spreading the tear film in front of the ocular surface. And approximately, it is fourfold reduction of evaporation due to lipid component. Now, regarding the tear film functions, the tear film functions by lubrication. It has an optical function. It has a protection function, a cleansing function, antimicrobial function, and it's very important for nutrition. Now we come to the ideal tear substitute that we always would like to have to be available in our hands. First, the solution should be isotonic. The pH should be neutral. It should be compatible with the natural components, so it does not alter the normal corneal surface and normal conjunctival surface and secretions. Does not alter the clarity of the aqueous layer. It's very important. as you know, that many patients may suffer from some types of lubricants that, although they are good and they are long-lasting, but whenever they install the drops, they feel that they cannot see very well until they blink maybe for 1 or 2 minutes in order to restore the clarity. It should reduce the surface tension of the tear film by its isotonic property. It should aid in formation of a hydrophilic layer, mucin, in order to catch the tear as long as possible. It should enhance tear volume with longer duration of action, because we know that the viscosity of the tear substitutes differ from product to product. So the more viscous, the longer duration of action. It should reduce the symptoms of the dry eye, and it should be preservative-free, or at least preservative of minimal risk to the corneal epithelium. So these are the properties of an ideal tear substitute. Now, what are the available tear substitutes in the market? I'm not going to talk about brand names. I'm going to talk about the families of chemical compositions. The first one is the cellulose derivatives. The second one is the polyvinyl alcohol. The third one is the carbomers, polyacrylic acid. The fourth one is hydroxypropyl GAR, propylene glycol. The fifth one is povidone, or polyvinyl pyrrolidone. And the sixth one is sodium hyaluronate. Now, starting with the cellulose derivatives, it is good. It has a good retention time on ocular surface. It mixes well with other ophthalmic products, and it has the viscosity that it has is not influenced by blinking. The polyvinyl alcohol is beneficial in lipid, aqueous, and mucin layer deficiencies. It is water soluble and does not cause blurring of vision. It has a short retention time on ocular surface, so it disappears quickly. It does not mix well with other ophthalmic products, so we cannot mix it with other products. The carbomers, or the polyacrylic acid, it has a good retention time on ocular surface. The povidone, or the polyvinyl pyrrolidone, it is beneficial in mucin layer deficiency. And the hydroxypropyl GAR, which is the propylene glycol, it mimics mucin layer of tears to prolong contact time and stabilize the tear film. It reduces squamous metaplasia in patients with dry eye disease, according to some studies. So it affects it calms down the metaplasia of the epithelium in severe dry eye diseases. Sodium hyaluronate, it has a good retention time on ocular surface. It is beneficial in corneal wound healing. And of course, later, Lunatus will talk about the sodium hyaluronate, the other benefits. Now, we have to put in mind that there are tear co-substitutes. What I mean by the tear co-substitutes, any of the previous products can be let's say, manufactured into emulsions, into lanolin and petroleum ointments and jellies, and into osmoprotectants. Of course, to be specific, not everyone can go through this, because there are special compositions that should be added in order to get these formulations, let's say. For the emulsions, they have, in addition to the lubricant, they have either mineral oil or phospholipids in order to replace the lipid layer. Regarding the lanolin and petroleum ointment or jelly, it's good for lubrication of the ocular surface throughout the night, so they cannot be used during the day because they are very viscous and they blur the vision. In addition, they have another benefit in retarding drainage of the tear film. The osmoprotectants, they are small organic molecules with a neutral charge and low toxicity at high concentrations. They act as osmolytes, and they help the ocular surface to survive in extreme osmotic stress. So as a take-home message, you have to remember that dry eye disease is a multifactorial disease. So it should be treated by multi-weapons. It is not only one weapon. There is no one solution. It causes loss of homeostasis of the tear film. It causes tear film instability. Instability because either the mucin layer is destroyed or the lipid layer is destroyed. So you have to diagnose which, or maybe both, and then you have to choose the proper treatment according to that. It causes tear film hyperosmolarity, which is the one or the first trigger of the vicious circle. There is inflammation and damage in every case of dry eye disease, even if it is very, very mild. So we have to grade the inflammation, know the source of the inflammation, and treat it properly. There is a neurosensory abnormality, so we have to check corneal sensation in every patient with dry eye disease. In addition, the treatment consists of patient education. Don't forget patient education. This will not only make the patient compliant, but also will make our treatment very easy. And the visits to the patient, to our clinic, are very comfortable when we find results and the patient is happy. Otherwise, we will spend more and more time explaining. So spend sufficient time in the first visit, and you will be comfortable the following visits. You have to manage the local environment problems of the patient. You have to discuss it, and you have to consider it. Then we can move to the treatment for the tear insufficiency. We have to treat lid abnormalities. We have to think about anti-inflammatory therapy, dietary modifications. Think about omega-3, although it is controversial and the studies are against it. Think about complementary medications. And this message is to pharmacists. Please consult ophthalmologists in every case of dry eye disease. It is not just a magic recipe. Thank you very much for listening, and I would like to give the stage now to Mina Ashraf to give his part.
Thank you, Dr. Mazin, for that talk. We've had many questions come in for you. We will save those till after Mina's short presentation. Mina, the floor is yours.
So I'll stop sharing now?
Yeah, I've already stopped it, Dr. Mazin.
Good. Thank you.
Okay, thank you very much, Dr. Thank you very much, Dr. Mazin, for this comprehensive presentation. I learned a lot, and I'm sure everyone enjoyed your speech. This was very informative. What I will be sharing is a brief presentation about Artelac Advanced. But just before I speak about Artelac Advanced, I will just discuss a little bit about what should be the general characteristics of an ideal tear supplement. And actually, to answer this question, I will refer to the Dry Eye Workshop Management and Therapy. The Dewes report said that in theory, an ideal artificial lubricant should be preservative-free and also should have a polymeric system to increase its retention time. And they described the elimination of preservatives such as benzalkonium chloride from OTC lubricants as the single most critical advance in the treatment of dry eye. Because non-preserved preparations allow the patients to administer the lubricants more frequently without the concern about the toxic effects of preservatives. So for patients with moderate to severe dry eye, according to the Dewes, the absence of preservatives is of more critical importance than the particular polymeric agent used in ocular lubricants. So before thinking what type of lubricant we should give, we should think first if this lubricant is preservative free or is it preserved. the reason behind that is simply because the effects of preserved eye lubricants are very well known. They cause an exacerbation of the ocular surface inflammation associated with dry eye, and also the epithelial toxic effects of benzalkonium chloride have been well established, and it causes sloughing of 1 to 2 layers of the epithelial cells. So, according to the Dry Eye Workshop Management and Therapy, preservative-free formulations are absolutely necessary for patients with severe dry eye, with ocular surface disease and impairment of lacrimal gland secretion, or for patients on multiple preservative topical medications for chronic eye disease because they are already exposed to plenty of preservatives in their different preparations. The second criteria of an ideal tear supplement, according to the Dry Eye Workshop, is that it should have a viscosity agent to provide longer interval of patient comfort. So viscosity agents increase the residence time, so they provide longer intervals of patient comfort, and also viscosity agents prolong the ocular surface contact, increasing the duration of action and the penetration of the drug, and they protect the ocular surface epithelium. So, and under viscosity agents, they mentioned hyaluronic acid as a viscosity agent that has been investigated for years as an active compound added to tear substitute formulations for the treatment of dry eye. And they mentioned that hyaluronic acid 0.2% has significantly a longer ocular surface residence time compared to 0.3% hydroxypropyl methylcellulose or 1.4% polyvinyl alcohol. So among the different preparations, we should always look at preservative-free preparations. And now we looked also at the second criteria, which is having a viscosity agent that prolongs the ocular surface residence time. And here we discussed about hyaluronic acid. So also, before we get into the product information, we need to look at hyaluronic acid among the different compounds available for ocular lubrication. What is hyaluronic acid? Actually, hyaluronic acid is the nature's high-performance moisturizer, and hyaluronic acid has few features that makes it an ideal tear supplement. First of all, hyaluronic acid is the body's own substance, which provides a very good tolerability. Second is hyaluronic acid has high water binding capacity, which provides superior lubrication and long-lasting ocular surface time. Finally, it has mucoadhesive properties, which provide long retention time, stabilization of the tear film, extended lasting effects on the ocular surface, in addition to its viscoelastic properties. And the viscoelastic properties of hyaluronic acid are actually similar to the natural tear film. It has what we call the non-Newtonian viscoelastic shear thinning. It has high viscosity when there is no pressure, but once a pressure is applied, and this happens by blinking, we see that hyaluronic acid loses its viscosity against pressure, and then it regains its viscosity again once the pressure is removed. So hyaluronic acid has enough viscosity to adhere to the corneal surface when the eyelids open, but under mechanical stress caused by blinking, they immediately reduce their viscosity, thus do not offer resistance. And this is what we call the non-Newtonian viscoelastic shear thinning. And thanks to this non-Newtonian viscoelastic shear thinning, we can see that hyaluronic acid has a superior rheological behavior compared to other lubricants. We see here the viscosity versus pressure of hyaluronic acid 0.2%, and we see here very high viscosity at rest, and then under pressure it loses the viscosity and vice versa, compared to very low viscosity all time with polyvinyl alcohol 1.4% and hydroxypropyl methylcellulose 0.3%. Consequently, hyaluronic acid 0.2% has longer lasting activity, and we see here the ocular surface clearance curves, the percentage of activity remaining compared to time. So at 0 seconds, once we apply, we always have 100% activity, but once we move forward with time, more remaining activity is shown with hyaluronic acid 0.2% compared to hydroxypropyl methylcellulose or polyvinyl alcohol. And also hyaluronic acid shows higher area under the curve, which is the total concentration on the ocular surface over 24 hours. And finally, hyaluronic acid does not only have these unique rheological properties, also hyaluronic acid induces stimulation of corneal wound healing, which is a pure pharmacological effect as described with this study. In this study, they compared different concentrations of hyaluronic acid, and they found that hyaluronic acid 0.2% and 0.4%, the higher concentrations, significantly speed up the time of wound healing compared to placebo or lower concentrations. Also, hyaluronic acid 0.2% helps in promoting epithelial regeneration, and this was superior to the lower concentrations, which were not very different from placebo. And 0.2% was similar to 0.4%. There was no additional difference. So that's why 0.2% is the optimum concentration of hyaluronic acid, and also in terms of promoting wound healing, and as we see here, the reparation of corneal epithelial denudation. Also, in a comparison between hyaluronic acid 0.2% and hyaluronic acid 0.18%, we can see that hyaluronic acid 0.2% provides superior reduction in corneal staining compared to hyaluronic acid 0.18%. Also, hyaluronic acid 0.2% provides superior reduction in pain versus hyaluronic acid 0.18%, which gets us again to the same conclusion of hyaluronic acid 0.2% as the optimum concentration. And this takes me to Artelac Advanced. Artelac Advanced is hyaluronic acid 0.2% preservative-free single-dose units. Artelac Advanced moisturizes, refreshes, and revitalizes the ocular surface. And as we know that dry eye is one of the most prevalent ocular disorders, with more than 16 million people in the US alone having dry eye. And dry eye can also cause contact lens intolerance and contact lens discontinuation, an increased risk of infection with ocular surgeries, poor refractive surgery outcomes, ocular surgery complications, if not addressed properly. So when we look at the results of Artelac Advanced, or the clinical benefits of Artelac Advanced in patients with dry eye, Artelac Advanced has a significantly longer mean half-life compared to hydroxypropyl methylcellulose and polyvinyl alcohol. Artelac Advanced has around 7 times longer ocular surface residence time compared to hydroxypropyl methylcellulose and polyvinyl alcohol. And as we can see here, that the ocular surface half-life, which is the time required to wash out 50% of the active ingredients from the ocular surface, we can see that polyvinyl alcohol, the ocular surface half-life is 39 seconds, hydroxypropyl methylcellulose is 44 seconds, while Artelac Advanced is 321 seconds, which is more than 7 times higher than HPMC. So Artelac Advanced is a molecule that stays the longest on the ocular surface, and also Artelac Advanced provides an ocular surface time for about 5 minutes longer than any other artificial tears. And that's why in all clinical trials that tested things like the tear film breakup time, we found that even after 6 hours of a single dose installation of Artelac Advanced, still the tear film breakup time was prolonged even after 6 hours. In addition, Artelac Advanced also significantly improves the ocular surface damage associated with dry eye syndrome in 3 months. As we can see in this study at figure A, which is before the initiation of treatment, the goblet cells were deficient and cells are large and polygonal, while after 3 months of treatment, there was an increase in the goblet cells in the sodium hyaluronic acid patients, and many small and very small cells were seen, which is an indicator in the improvement in the cytological grade score with Artelac Advanced. Also, Artelac Advanced speeds up the wound healing process. As we can see here that Artelac Advanced healed 60% of the corneal damage in 12 hours, and it achieved complete healing in 2 days. And here we can see that there is a significant reduction or in the time required for wound healing, and the percentage of the wound area is significantly declining versus time. So it shows that Artelac Advanced significantly speeds up the wound healing process. As a conclusion, Artelac Advanced is hyaluronic acid 0.2%, which is the optimum concentration, preservative-free as recommended by the Dry Eye Workshop Management and Therapy. It's an 0.2 hyaluronic acid, preservative-free, that improves the stability of tear film and moisturizes the eye. It's preservative-free, well-tolerated, easy to use because it's single dose units, and the SDUs are re-capable, so we can put the cap again, and it's suitable for all types of lenses, and contact lens wearers are also people who might benefit from Artelac Advanced. Thank you very much and for your attention. And again, thank you for your presence in this webinar. And thanks to Dr. Mazen for his beautiful lecture. And I leave the floor again now for Gerard to handle the questions. Thank you.
Thank you, Mina. Thank you for a very nice presentation. And thank you again to Dr. Mazen. We've been having many questions, both on the public forum and the private forum. So I will just dive right in to you, Dr. Mazen. As a pharmacist, when should we treat dry eye using OTC lubricants, and when should we refer to ophthalmologists? Dr. Mazen, your sound seems to have disappeared again.
Can you hear me now?
Mazen, yes, we can hear you now.
Okay, great.
So if you start, yes, please start again.
Yeah, okay. Now, I'd like to thank Mina for his very nice presentation. I'd like to thank all audience who sent me. Thank you, Dr. Mazen, for your informative presentation. Thank you all for attendance. Now, when to refer the patient from a pharmacy to ophthalmologist? First, when the patient has red eye. Okay, if the patient has only some symptoms of dryness without redness, without something very clear in his eye, then this is one of the cases to treat it directly. Otherwise, to refer to the ophthalmologist. Second, if the patient is suffering in spite of using the lubricant, still suffering, then we have to refer. If the patient has any background of immune problem, like Sjogren disease, rheumatoid arthritis, or anything, then we have to refer it to the ophthalmologist. If the patient has other symptoms, like, for example, itching, maybe there is another problem in the eye. It is not only dry eye, or blurring of vision, for example. So if it is only dryness without any other symptoms or signs, it's fine to treat it in the pharmacy. Otherwise, we should refer it to the ophthalmologist.
Okay, thank you, Dr. Mazen. A private question I received is, how can I differentiate between itchiness due to allergy and the one was caused by dryness? What are my key points to look out for in the pharmacy?
There is no way in the pharmacy to differentiate. The patient should be investigated and should be examined by the slit lamp in the eye clinic, and sometimes we need some tests as well.
Okay, thank you. Another question coming in is, how, or is there a possibility that multivitamins and supplements that people take can become a risk factor in causing dry eyiness?
Yeah, I will ask this question actually to the TIFOS Dues too. Something scientifically approved, but I don't know what is the mechanism of this. I don't have an idea, but it is found in the TIFOS Dues too that it is one of the factors.
Okay, thank you. What is the difference between preserved and preservative-free eye lubricants?
Okay, the preservative-free, they just have the lubricant without any preservatives like benzalkonium chloride or others. While the preserved, it means that they include a preservative, and usually this preservative is added when there is a bottle rather than minims. The bottle, because it have a big amount, and the manufacturer would like to keep it vital and usable for example, for 1 month. So, but however, there are new systems in the bottles, even without preservatives.
Okay, thank you. What is the dose of Artelac Advanced that should be given to dry eye patients?
Yeah, very good question, because in my clinic, I usually depend on the severity of the dry eye. I tell the patient, as much as possible, you can use it every 2 hours, you can use it every 4 hours. But there is another point, which is people who are spending long hours on the computer, I advise them to use 4 times a day, okay, as basic, and more if they feel some symptoms.
Okay, thank you very much. A general question about side effects. Is there any suggestion of side effects for overuse of lubricants, or any side effects in general? Perhaps I think question for both speakers here.
There is no side effects at all for overuse, but it is like economic burden. A lot of cost, insurance will cover, will not cover, cash patient. So why to use something not necessary? This is the point.
Understood. Is there a big difference between the 1% and 2% in terms of efficacy?
I think this is a question to Mina, but from my side, clinically, the 2% is better, more effective, of course.
Yeah. Well, actually, thank you, Dr. Mazen. Just for the, can you hear me now?
Yes.
Okay, so in the studies that compared the different concentrations of hyaluronic acid ocular lubricants, they compared two things. They compared the lubrication and the moistening effect, and also they compared the wound healing properties of hyaluronic acid. So across the studies, they found that in terms of lubrication, below 0.1%, hyaluronic acid loses lots of its water binding properties, and above 0.2%, there is no really additional value or no clinically significant difference in terms of added value, but the tolerability is compromised. So that's why 0.2% is an optimum concentration in terms of ocular moistening. In terms of wound healing, there was no difference between the 0.1% hyaluronic acid and placebo in one of the studies that I showed in terms of speeding up the wound healing properties. But there was a significant increase or improvement in the wound healing time, a speeding up of the wound healing time with the hyaluronic acid 0.2 and 0.4%. And again, the 0.4% did not provide any added value compared to the 0.2%. So that's why the 0.2% is believed to be the optimum concentration of hyaluronic acid, both in terms of ocular moistening and also in terms of promoting wound healing and epithelial regeneration.
Thank you, Mina. A question here is dry eye common with patients that have rheumatoid arthritis? Do you see that in your clinic, Dr. Mazen?
Yes, it is. It's very common, yes.
And what are the signs? How can they treat that?
Yeah, we have to control the rheumatoid arthritis. The rheumatologist will do this, of course, and we have to treat the ocular surface.
Yeah, okay. Another question here. How many doses are in one vial of Artelac?
I think it would be sufficient for about 3 or 4 4 times like this, 3 or 4.
And how long should patients use Artelac Advanced?
As long as dry eye is there, because of course, when we treat the source of the dry eye, then the patient will be less dependent on the lubricant. Okay, so maybe we will start like every 2 hours. Then, by controlling the ocular surface disease properly, then maybe it will be 4 times a day, and then after maybe 1 or 2 months, then it will be like on demand.
Okay. Another question is, do we need to use anti-inflammatory eye drops with lubrication eye drops in dry eye syndrome?
Yes, and this depends on the symptoms and signs and the grade of the inflammation, because as I said, inflammation is there in every case of dry eye disease, but according to the grading, usually whenever it is moderate or severe, we have to use anti-inflammatory. If it is mild, we don't need to use the anti-inflammatory. Another case to use the anti-inflammatory when there is MGD, meibomian gland dysfunction, or blepharitis. We have to use the anti-inflammatory.
Okay. Another question is, hyaluronic acid, excuse my pronunciation, as a medication for treatment of dry eyes, is it safe for patients that have cataracts or glaucoma?
Yes.
Yes. How frequent would you give autologous plasma in patients with severe dry eye or in patients after keratoplasty?
Yeah, the autologous serum.
Yes.
Actually, using the autologous serum is very rare. We seldom use it because if we diagnose the dry eye disease and the ocular surface disease properly and the background properly, and we control everything properly, then seldom that we reach this point to use the serum, this type of treatment. However, if we need it, then we have to, there is a special formulation, and we have to use it twice daily. And very rarely we may need it 3 times daily.
Okay, thank you. If a patient of dry eyes has corneal staining, suppose inferior of 1/3, then should antibiotics be part of the lubricating therapy?
Very good question, because usually when there is staining in the inferior part, there are 2 reasons for this. Either the eye is not closed properly during sleep. Okay, so there is a part which is exposed during sleep, and the patient should be educated how to avoid this, maybe taping the eye, maybe using the ointments, mineral ointments at night. And the other cause is the meibomian gland dysfunction and blepharitis. If it is meibomian gland dysfunction or blepharitis, yes, we have to use antibiotics, special antibiotics for this, for the MGD and blepharitis, like, for example, the azithromycin, for example. But we don't use general antibiotics as drops, but just because of the staining.
Okay, thank you. A 2-part question is, for how long is it safe to continue to use Artelac Advanced? And could ocular dryness ever be permanently cured?
Yeah, good question. Now, regarding the last myth that I showed, a dragon and the night, that it is unbeatable. Actually, yes, it is beatable, but if we use the proper weapons. So if we study the patient properly, if we control everything properly, then we will control the dry eye disease and ocular surface disease, and then we will come to a point where the lubricants can be used just on demand, per needed. So lubrication is essential for everybody nowadays, because our environment, because we are spending long hours on the computer, because we forget to blink, we forget to drink water, we are exposed to AC. So we can't come to a point that everything is controlled, but we still need the lubricant. So the lubricant can be used even for a long period of time without any side effects.
Okay, thank you. Some more questions coming in here. why is dry eye more after LASIK?
Yeah, of course, because we are cutting the nerves by the LASIK. We are creating the flap. So there will be lack of sensation in the cornea, and this will initiate the inflammatory cascade, and the patient will have hyperosmolarity and dry eye disease.
Okay. A private question here is, do you know a new technology for the evaluation of the meibomian glands?
There is meibomiography, of course, that we do imaging to the meibomian gland in order to see the number and the quality of the meibomian gland. Yeah.
Okay, I think we'll finish on this question. A private question again is, can we give patients a combination of hyaluronic acid drops and gel together for severe eye dryness?
Usually the gel is given at night, and the drops are given at during the day. So no problem if we combine. Usually we combine like this. Yes.
Okay, thank you very much. I will just do the final housekeeping, and then I will pass back to Dr. Mazen and Amina for the final comments. As mentioned at the start, this webinar has been recorded and will be active for 3 days after this webinar. You will receive an email very shortly that will allow you access to go back and watch it again. Your attendance certificates will be sent to you within 2 weeks of this webinar finishing. We will send it to you directly via your email. I'd like to thank Lunatis and Bosch Health for organising this webinar, and to Dr. Mazen for giving an excellent presentation. And we could have spoke for all night with the amount of questions that's coming in. Dr. Mazen and Mina, I'd like to hand you back for your final comments before I close this webinar. Thank you. Dr. Mazen, please.
Thank you, Gerard. Mina, please, first.
I just want to say thank you very much to Dr. Mazen for the informative presentation. And we can see from the comments how all the audience are very happy with the content that they have received. So thank you very much. And thank you very much to all the audience. Sorry we kept you late at night, and we really appreciate your presence. It's a pleasure to have you all. And thank you, Gerard, for taking care of all the organizations. Thank you.
Thank you. Thank you.
Thank you. I would like to thank Lunatus for this invitation again. It was a pleasure to be this night with this mashallah, very good amount of audience and listen to Mina presentation. Thank you, Gerard, for hosting and moderating. Thanks to everybody.
Thank you, gentlemen. And with that, I will now be ending the webinar. Thank you and good night.
Good night.